Hello, everybody, and welcome to the second lung cancer screening webinar. Speaker is Dr. Annemiek Snoeckx from Antwerp, Belgium, and she will talk about technical requirements for lung cancer screening, how to perform the acquisition, dose, slice, thickness, how to read the scans. Thank you very much, Annemiek, for your time. You can start now.
Thank you, Ricarda, for the nice introduction, and thank you to the ST for inviting me to give this second webinar in regard to the lung cancer screening certification project. So the topic of today is technical requirements for lung cancer screening. So this is the outline of my talk. After a brief introduction, I will discuss the topic of radiation. Then I will briefly go over the technical aspects of some of the lung cancer screening trials. And the biggest part of my talk will be about the ST document of lung cancer screening technical standards. At the end, I will very briefly discuss a short perspective on the future. So this is a pathway for implementation of lung cancer screening. It starts with recruitment, risk assessment, association with smoking cessation, and then it goes to low-dose CT and eventually to diagnosis and treatment of hopefully an early lung cancer. Radiologists play a crucial role in two of these major steps. The first is, of course, the low-dose CT lung cancer screening, and the second step is the diagnosis, imaging involved in diagnosis or image-guided interventions that are related to the diagnosis. I think it's evident that there will be differences on how lung cancer screening will be implemented in the different European countries, but on the other hand, there also will be a common ground. You're all probably aware of this paper. It is the landmark paper of Wilson and Jungner on the principles and practice of screening for disease. This manuscript was published by the World Health Organization in 1968, but even all these years later, it is still very accurate. And what do they say about the screening test? A test must be acceptable and cause minimal disturbance to the subject in its performance. And it seems that low-dose CT fits these criteria. Screening is a trade-off between the benefits and harms, and it is evident that the benefit is saving lives by early lung cancer detection. There are, however, some harms involved, and in the context of the technical requirements, the harm we are talking about now is radiation dose. So the targeted radiation dose defines what technical standards need to be used, but on the other hand, the technical standards that will be chosen will define the dose of radiation that has been given. So something about radiation dose. Does dose matter? I think we all know that it does, but why? The problem with radiation for screening is that it also induces disease. We will detect cancers, but we will also cause cancers. And in screening, this is defined as the detection over induction ratio. In a paper of 2004 from Brenner, he stated that the risk of radiation-induced lung cancer associated with repeated low-dose CT screening in smokers may not be negligible. And well, why is that? There are three reasons. First of all, there is age. We all know or we think that the risk of cancer induction decreases with age. And this is definitely the case for most organs, as you can see on these graphs. But while radiation-related cancer risks generally decrease with increasing age, at exposure, risk of radiation-induced lung cancer show a different pattern. And the lungs, they are more sensitive to radiation at an older age. And if you look at the graphs, you can see that at the age of the time of starting of lung cancer screening, the lungs are most vulnerable, in contrast to all the other organs. So secondly, there is the aspect of gender, and we all know that it is known that the lung of women are more sensitive than those of men. It is kind of unclear what the reason is, but more than probably it is hormone related. So it's a good thing that lung cancer mortality reduction is higher in women than in men, because more cancers will be induced in the female population. So we had age, we had gender, and the third aspect is smoking. We're not irradiating healthy lungs in lung cancer screening, but since we're targeting high-risk smokers or former smokers, we will be irradiating damaged lungs. And it is known that there is an interaction between radiation and smoking, and this interaction is not additive, but the effect is multiplicative. So does those matter? I think we all know why, but this is just a reminder. It matters because of the age, it matters because of the smoking, and it matters because of the gender. So before we look into the present, I think it's a good idea to look briefly into the past and see what the technical parameters were during some of the lung cancer screening trials. It is evident, I think, that the trials from the 19s had different settings than nowadays, with the IL-cap having slice thickness up to 10 millimeter and using a helical CT. Almost a decade later, in the Dante, slice thickness was reduced to 5 millimeter, and multi-detector CTs with 1 or 16 rows were used. In the LNST, the majority of scanners were 4-row detector scanners with an effective dose around 2.4 millisievert. These are the technical parameters of the Nelson. Only 16 slice detector CTs were used, and the CT dose index was set to be adjusted to the participant weight with effective doses of 0.8, 0.6, with the CTDI value estimated of 0.8 to 1.6 and 3.2 milligray. Relatively similar settings in the Danish lung cancer screening trial, and then the ITA-lung, more variable parameters, probably related because they had different types of scanners, single slice 4, 16, and 64, and they also adjusted according to body size. In the mild trial, scan parameters were set to obtain an average effective dose not too high of only 0.7 millisievert. And then in the German Lucy trial, average effective dose was about 1.6 to 2 millisievert. And the UKLS has a relatively similar protocol to the Nelson trial with CTDI volume based on weight of the participants. So this is a brief overview of what were the technical standards of some of the most important trials in the past. So now I want to present the ST technical requirements for lung cancer screening. We're almost 30 years after start of the first lung cancer screening trial, so a lot of things have changed and are possible nowadays. So what is important to take in account? First of all, noise needs to be acceptable, but because of the contrast between lung parenchyma and the nodules, noise can be relatively high. Secondly, the scan protocol needs to allow computer-aided detection as well as accurate volumetric measurements. Morphology of the lesions should still be able to be appreciated. For example, the ground glass component needs to be depicted in part solid nodules and needs to be differentiated from the normal parenchyma. And last, some lung cancer prediction models take into account emphysema, so this also needs to be appreciated on your low dose scan. So the document of the ethical technical standards is divided in 5 aspects. First, there are participant-related factors. Secondly, there is radiation dose. The third aspect is the acquisition protocol. The fourth aspect is image analysis. And last but not least, quality assurance. The document that we'll be discussing is available on the ST website. You go on top to the tab Lung Cancer Screening Project, and there you can find the file technical standards. So, first part, participants related. I think some things are evident from the chest CTs that we do in daily practice, such as positioning of the patient in the center of the gantry, supine position and arms over it. The correct positioning ensures appropriate application of automatic exposure control, and it will also avoid asymmetric distribution of noise and artifacts. The scout image should only be limited to the chest, and after it is taken, it should be inspected for external objects. The entire lung volume should be fully scanned from lung apex to the lung base, but no more than the lungs, in contrast to the studies that we do for thoracic oncology, where we have the adrenal glands included. This is not the case in lung cancer screening. It is evident that the gantry, that there's no need to tilt the gantry, and the display field of view is 1 centimeter beyond the rib cage. It is not really necessary to include the entire chest wall, and if you have a smaller field of view, it means that you have smaller voxel size and your volumetry will be better. So this was the first topic. The second topic is radiation dose. So what is proposed by the ST as a CTDI volume-based guidelines? They are based on participant weight. For very thin participants, less than 50 kilograms, 0.4 milligray CTDI volume. For participants between 50 and 80 kilograms, 0.8. And for participants, which probably will be the majority, of more than 80 kilograms, 1.6 milligray. The 1.6 milligray in effective dose will correlate around for a male to 1 millisievert. So last month, a paper was published in JAMA Internal Medicine regarding radiation doses that were used for lung cancer screening scans in the US. And they looked at about 12,500 participants in 72 institutions. And as part of the Medicare reimbursement in the US, dose has to be registered in a dose registry. And just as to compare with our guidelines, the dose proposed by the ACR is a CTDI volume of 3 milligray or lower. So of the 12,500 CT scans, they found that 18% had a CTDI volume that was higher than the guidelines, where you can see here in the chart. And then when they looked at the effective dose, 50% of the participants had an effective dose that was higher than the ACR guidelines. So why am I showing you this study? It is mainly because they also looked at the reasons why the dose was higher than allowed. So a higher dose was noted when the medical physicist was external instead of being on staff at the institution. And then when they also looked at the medical physicists, just having any type of medical physicist establish the lung cancer screening CT protocol, this was associated with decreased odds of exceeding the 75th percentile benchmark. And then when they looked at the radiologist, there was a higher dose when any radiologist in the department could establish the protocols, but institutions with a lead radiologist, so a lead radiologist responsible for the lung cancer screening, if they were able to optimize the protocols, they had a 27% lower CTDI volume. So the type of personnel involved in establishing protocols has an impact on CT radiation doses delivered, and fewer individuals involved in scan protocols may avoid unnecessary variation in radiation doses. So I think what this study emphasizes is that there is an important role for radiologists and medical physicists in radiation dose in low-dose CT lung cancer screening. So we've been talking about the dose for low-dose CT in lung cancer screening, but there's also dose involved in the next step, the step of diagnosis. There is dose involved in the short-term follow-up of low-dose CT, for example, for indeterminate nodules. And when a suspicious finding is found, there is dose involved in the diagnostic CT, the FDG PET, and also if it is planned CT-guided biopsy, there is dose involved. There is not much data about dose in lung cancer screening trials, except the ITA-Lung. They looked at the total amount of dose given in their trial. And 77.4% of the dose came from the annual low-dose CTs, but almost 1/4 of those came from further investigation. So concern about dose is important for your screening trial, but is also important for everything that is involved in the diagnosis. So we've discussed the participant-related aspects. We have discussed the radiation dose. Let's go over to the acquisition protocol. As a scanner type, a multi-detector CT with 32 or more detector rows is advised, and even more if it's preferred to have 64 or more detector rows if available. It is evident that we are talking about low-dose CT for lung cancer screening. There is no IV contrast involved. Regarding the KVP, 100 to 120 is acceptable for a standard size participant. You might need to increase the KVP to 140 if your participant is extremely obese. Preferably reduce mass first and then KVP, and if you have a thin filtration CT, that is strongly advised. The tube current should be set in combination with the KVP and the pitch. And then what about the adjustment in scanner output for participant size? No fixed MES setting unless at very low dose, less than 0.5 milligray. Tube current modulation is recommended. And this should take into account participants' body habitus, age, slice width, KVP, and the unique attributes of the scanner and acquisition mode. And then noise level settings should ensure diagnostic quality of the lung parenchyma, because that's what we're looking at, and of course, accurate volumetric measurement. If your scanner has organ dose modulation and automatic exposure control, that is recommended to use. So the maximum tube rotation time should be less or equal than 0.5 seconds. The pitch should be set with other technical parameters to achieve the CTDI as specified. Reconstructed image width should be equal or less than 1.0 millimeter, preferably 0.75 or even smaller. And in very obese participants, 1.25 may be necessary to achieve the low radiation dose. The smaller the image width, of course, the better the resolution. The slice interval should be equal or less to the slice width. Overlapping reconstructions are not really mandatory. The reconstruction kernel is the standard body kernel for the volumetric measurement, and an additional lung kernel can be suggested. As a reconstruction algorithm, you will need the iterative reconstruction to achieve a low dose protocol, or you can use, if available, deep learning reconstruction algorithms. Use a filter back projection is discouraged. So we've discussed the participant-related factors, the radiation dose, the acquisition protocol. Let's go over to step 4, image analysis. So window settings are lung and mediastinum, with lung, of course, preferred, since mediastinum window settings, because of the low dose, mediastinal structures are hard to evaluate. I think it's evident that the reading needs to be performed on a system that allows scrollings and reformats. And we all know that the detection of nodules is definitely increased when you use MIP, maximum intensity projections, and sometimes multiplanar reconstructions can be useful if you see lesions that are more difficult to characterize. So reading of the images, who should read the images? We believe that the images should be read by a qualified radiologist experienced in pulmonary nodule imaging. When early lung cancers present as a nodule, the diagnosis is, I think, kind of evident, but there are a number of tumors that are more difficult to detect, such as endobronchial lesions, lung cancer presenting as lymphadenopathy, lung cancer associated with cystic air spaces, pleural attached lesions, or sometimes nodules in areas of reticulation or nodules in underlying lung disease. I suppose most of you are familiar with this study published in Radiology. This study investigated to which the addition of category 4X improves performance of lung rats for predicting the probability of malignancy of part solid nodules and subsolid nodules in general. So in this study, lung cancer screening exams were reread by 6 experienced chest radiologists, and they had to define which of the subsolid nodules to classify as being suspicious and specify the morphological features what made them look suspicious. And the readers were successful at increasing malignancy rate in category 4X to approximately 50%, but then they looked into the morphological criteria and there wasn't really a consensus. I think what this study shows is that experience is extremely important, and why a nodule looks suspicious is very difficult to capture in specific criteria. It is experience created by seeing many nodules, going to the multidisciplinary tumor board, correlation with pathology. So I think expertise is extremely important. So radiologists qualified and experienced in pulmonary nodule imaging and management is a very important aspect. When we talk about qualified radiologists, the question or remark raises about the fact that we don't have enough chest radiologists for the moment. The shortage of dedicated radiologists and capacity will differ for every country in Europe and will be probably more problematic in some countries than in other countries. But it's not because we don't have enough chest radiologists now that it cannot change. This was also the case, especially in our country with breast cancer screening, but we trained radiologists dedicated to breast cancer screening. So I believe we can train radiologists dedicated to lung cancer screening and dedicated to pulmonary nodule management. So the country in Europe which currently does the most experience with lung cancer screening, I think, is UK, and they already have looked into different scenarios to overcome the problem of not having enough chest radiologists and investigate the role of technicians and radiographers. So second point about the reading is the use of a CE FDA-approved computer-aided diagnostic system to allow lesion detection and volumetric measurement. When we look into the screening trials in the LNST, one reader was the only trial with one reader, and then the other trials used double reading, at least in the beginning, and CAT was used as a second reader. In a study from the Nelson Group from 2012, published in European Radiology, they looked into 400 CTs, and they showed that 22% of nodules would have been missed without CAT, and that this also showed that the sensitivity of the readers could have increased from 78 to almost 97% if CAT would have been used. They also showed that if the volume was set as a threshold for the CAT system, so volume as threshold and not size, the false positive findings were also reduced from 3.7 to 1.9. So CAT is definitely valuable in lung cancer screening to improve sensitivity of nodule detection beyond double reading. The third aspect in the reading is the volumetric measurement. You've probably all seen this image many times. I think it beautifully illustrates the impact of volume compared to growth. What do we need for lung cancer screening? So what we need for lung cancer screening are volumetric measurements. And why do we need them? Because detection of early growth is the essence of screening. So there are different parameters that influence volumetric measurements, and one is the CAT software. So the same software and even the same software version is mandatory for volumetry in follow-up studies. And in case you change the software during your screening process, the nodule size from at least the previous study has to be reevaluated to be able to compare with the current study. So for those who want to know more about the impact of technical factors on volumetry, I can strongly advise you this great paper from Anand published in Radiology. It gives a really nice overview of the impact of all the different parameters on the variability in volumetric measurement. And this is a table from the Quantitative Imaging Biomarkers Alliance from the RSNA, and it shows the minimal detectable change in tumor volumes. It's not only about the nodules, also about larger lesions, but it clearly demonstrates what is important. So the worst case scenario to detect small changes in tumor volume are if you use a different scanner, a different radiologist, and a different analysis tool. And the best scenario is you use for your study the same scanner and same settings, same radiologist to read the image and define the volumetry, and the same analysis tool, the same software, and then you can find the smallest change in volume. So last part of my talk, we've discussed the participant-related factors, radiation dose, the acquisition protocol, and the image analysis. Last is an extremely important one, and this is quality assurance. We have mentioned the medical physicist before. Close collaboration with a medical physicist is definitely mandatory. Periodic quality controls are specified based on the national guidelines. And then besides the official and local regulations, which is just monitoring, registration, and periodic optimization of scan procedure parameters, radiation dose, scanner performance, image quality, and reader performance. Only if you monitor and you register, you will be able to optimize all these parameters. This is very brief about the quality assurance, but quality assurance is very essential in lung cancer screening, and quality assurance is needed in every step of the lung cancer screening process. So a very brief look into the future. What does the future bring? We're talking about low-dose CT, but probably ultra-low-dose CT will be available for lung cancer screening and is definitely under investigation for lung cancer screening. There are denoising and deplurging algorithms to decrease the noise for your low-dose examinations. There's evolution in CT with photon counting, detector CT. And then I think artificial intelligence will definitely have a role in lung cancer screening. We will have a huge amount of data. And if we try to set the same parameters, this will give a huge possibilities for artificial intelligence to obtain a lot of information. And do we need to be afraid about our role as radiologists in lung cancer screening? Until everybody is still demonstrating this as lung cancer screening with a chest radiograph and funny colored images, I don't think we need to be afraid that we have a role in screening. So I want to thank you for your attention.
Thank you very much, Annemiek, for this very interesting presentation. We have now a few minutes to answer questions. So if there are any questions, please use the raise the hand button or type in your question in the chat function, and I will be happy to read it out. We give you a few minutes. Okay, I have received a question from Lisandro Paganini. Thank you very much. Do you use ACR lung rods?
ACR lung rods has, I think, nothing to do with our technical standards, and the nodule management will discuss in further webinars. So I don't want to go into detail, but I think the ACR lung rats is mainly based or was mainly based on nodule size. And I think the ST definitely is going for volumetric assessment. So, but the nodule management systems will be discussed. I don't know, Ricarda, in which webinar, but there is definitely one about management of solid and management of subsolid nodules.
Okay, thank you very much. We have a question from Marie-Pierre Well. Hello, Marie-Pierre, can you hear me?
Yes, I can hear you. Yes, congratulations, Annemiek. It was very interesting and clear and important that you indicate all these requirements. You mentioned that our colleague from UK performed some research to compare the performance between technologists and radiologists. Can you tell us more about it?
Yeah, I think they compared technologists or radiographers as having the first read, not replacing the radiologist, but there might be a role in pre-reading the examinations, and then have some of the examinations go to the radiologist so that the workload isn't that high. So I think further research is needed to see in which role they may have. Maybe there is a role for radiographers and CAT as first, and then only go at only a certain amount of studies, or the difficult studies with lung disease or interstitial lung disease, that the difficult studies go to the radiologist. So, but I think these are just two studies. I think further research is needed. And I think, maybe for a number of examinations where it is very clear that CAT doesn't see anything, and then in combination with a radiographer, that might be a solution if there is a shortage of radiologists.
Okay, thank you.
Thank you, Marie-Pierre. Are there any further questions? Okay, I have received a question from Michael Dupont. For how long it is recommended to keep the submillimetric slices on the pucks?
I think it is recommended to keep your thin slices always on the packs, because you will need them for further examinations and to do the follow-up. So I think only keeping reconstruction images is not a good idea, and you will need the thin slices to do the reconstructions afterwards.
Thank you. We have received one comment from Isabella Muller, an excellent presentation. Thank you. And I have received a question from Tai Lu. Since there is more chest radiologists in other European countries, is there a network in the ST where countries who have lack of chest radiologists can use their expertise?
I think there are a lot of initiatives from the ST. There is this initiative from the Lung Cancer Certification Project, which the webinars are just only one part of it. There will be also workshops. There will be lectures regarding nodule management. There will be lectures at ECR. So I think the ST, and there will also be lectures on this topic on the annual meeting. So I think the ST has a number of aspects that they do to train radiologists in pulmonary nodule management. And I said before, it doesn't only need to be dedicated chest radiologists, but you can also train radiologists that were not dedicated to chest, but train them for pulmonary nodule imaging and train them for lung cancer screening. So but I think the ST has a lot of initiatives, and I think the lung cancer screening project is a very good initiative to increase expertise in nodule management.
Thank you. I think we have no more questions. So I will address your attention to the next lung cancer screening webinar. The date is November 25. The topic is solid nodule morphological evaluation, how to recognize obviously benign malignant nodules, how to recognize intrapulmonary lymph nodules and pitfalls. The speaker will be Anand Devaraj from London, UK, and we will open the registration beginning of November. Thank you again, Annemiek, for your time. Oh, in the meantime, I have one last question from Diana Pena. Should we ever discharge patients from lung cancer screening, or should we periodically keep scanning patients without suspicious nodules?
So what is the question? Should we?
Yes, sure. Should we ever discharge patients from lung cancer screening, or should we keep periodically scanning patients without suspicious nodules?
I think the most important thing is that if you have a participant that is in a lung cancer screening, has lung cancer screening in a trial or in a population-based screening, that you need to follow the guidelines from your screening and don't do anything that is not in the guidelines. So if there is no nodule, and yeah, it's just annual follow-up until the end of the age of your screening program. So I think quality assurance and doing every step as guided by your lung cancer screening program is extremely important.
Thank you, Annemiek. Okay, so let's close the webinar. Thank you everybody for joining, and we are looking forward to welcoming you to the next webinar end of November. Bye.
Bye-bye.